I'd like to welcome everyone to this afternoon's Jones Seminar. I'm Keith Paulson. If you come regularly, you usually see another person here named Brian Pogue. Brian asked me to step in for him and host this afternoon's seminar today, and it's a distinct pleasure to do so because today's guest is really a superb investigator, researcher, faculty member here at Dartmouth and the Geisel School of Medicine, someone who I've known for a number of years, so it was a real pleasure for me. And let me say, Lisa Marsch is the Andrew Wallace Professor in the Department of Psychiatry within Geisel. She runs a large center called the Center for Technology and Behavioral Health. I think scanning, there's some other information you probably read about Lisa. I think in scanning her CV, I had a chance to look at it a few minutes before here. What's really most impressive, two things catch my eye. Her programs are extremely well funded by the National Institute of Health. I think I read she's been awarded up to almost 30 competitively received awards, including very large ones in the multi-million, 5 million and up amounts for her work. Equally impressive, though, not only is she a fantastic researcher, she's well recognized at the highest levels of the country and the world. She speaks at the White House, has spoken before congressional committees, the Surgeon General, and in other venues. Now, I did have an opportunity to do a little more rooting around. Those are kind of things you can find. And there I did come across some inside information. I did learn that Lisa is known in some circles, as I hear it, as the gift from Sydney, Australia. Now, I didn't really get the full context, and maybe if Dr. Marsch has a moment, either at the beginning or the end of the seminar, she might elaborate a little bit on that, but that's what I did find out. So it is a real pleasure to have Dr. Marsch speak to us today on the broad topic of digital health. And you can see the rest of her title. So, Lisa, thanks for coming.
Well, thank you so much for that introduction and for the invitation to come and speak with you today. I'm thrilled to be here and to talk with you about our work and our center. And I guess I have to comment on this. I'm not from Sydney, Australia, but I first met the department chair of psychiatry at Geisel at a conference in Sydney, and we both spoke back to back, and he then asked me to come give grand rounds for the Department of Psychiatry at Dartmouth, and that started a relationship with a lot of folks here at Dartmouth, and eventually a move from New York City to Hanover, New Hampshire. So that's thank you for doing that background digging there. Okay, great. Well, so today I'm going to talk about digital health, and I'm going to talk about sort of the space of digital health and what's been evolving in the research arena around this, and what are the opportunities in transforming how we think about medicine with digital technology. But I'm also going to take some time to talk a bit about our center, which is here at Dartmouth and is really designed to be an interdisciplinary partnership across the Dartmouth community. And I want to tell you a bit about it and highlight some of the research interests and activities of the center in the hope that perhaps we could expand some collaboration with colleagues and students here at Thayer. We've been very fortunate to have some faculty affiliates at Thayer who work on various projects in the center, and we would love to explore opportunities to expand that. So I'm going to go through some slides, and I'll watch the clock so I make sure I protect some time for questions and discussion at the end. So in addition to my faculty appointment here at Dartmouth, I also have an affiliation with a couple of small businesses. We've been increasingly building some academic industry partnerships for dissemination of some digital tools that we've been involved in developing and testing. And here are some small businesses that I have an affiliation with. And then I'd also like to acknowledge our funding. Here are some of the grants that I'll speak about today. We've been very appreciative of the support of the National Institutes of Health, including a center grant we have from the National Institute on Drug Abuse, which has supported the infrastructure of our Center for Technology and Behavioral Health here at Dartmouth. Okay, so we're talking about digital health, and when you think about digital technology, it has just transformed so much of our world, our society, how we live our daily lives, in terms of how we have social communications and how we do retail and finance and education. And the space that we work in is how can digital technology and the rapidly advancing field of digital technology impact how we think about health and wellness and healthcare delivery. And so really trying to harness the ever-growing availability and ubiquity of digital devices globally, really, to think about new resource delivery. And so digital health is the space that we work in, and really what that means is how can digital technology both help us understand health behavior and health sort of disease and clinical trajectories in new ways, but also how can we offer interventions and resource delivery in the health space in new ways as well. And the term digital therapeutics is really referring to software that can help treat a disease indication. And this is a space we've worked a lot in. So today I'm going to talk about digital therapeutics as well as some of our work in digital health sort of measurement in areas like digital phenotyping, which I'll describe to you a bit later, as well as some work in analytics in this space to really think about how can we best glean insights from the rich data we can get from digital devices to understand individuals and provide very responsive resources and intervention delivery to individuals across a lot of different health domains. So starting with digital therapeutics, these digital intervention tools, the idea here is that this is kind of like a clinician in your pocket, right? It's kind of like 24/7 you have access to therapeutic support that might be of relevance to you and your and maybe a clinical condition that you're managing. And so the goal here has been heavily to extend the reach and the impact of our healthcare workforce. How can we sort of supercharge the workforce by giving them additional tools that are science-based, that are personalized, that can extend their reach and the impact that they can have with the patient population that they're working with. And so the idea is that this could extend reach and capacity for care. It can also improve patient outcomes. And there's a lot of data, which I'll describe to you today, that underscores that this is the case. One of the very exciting things about this is scalability, right? So anytime, anywhere healthcare, anytime, anywhere access to resources available via digital platforms. So just to comment on something that you all know very well, we know that access to mobile technology and access to the internet has been just growing at exponential rates globally. We know that the majority of the world's population has access to mobile devices, and they're not all smartphones, but increasingly we're seeing globally dramatic increase in access to smartphones, which have enormous, as you know, computational capacity and opportunity to harness the power of these tools. And we also know that even some of the most traditionally sort of disadvantaged or vulnerable populations you can think of are experiencing these same trends of increased access to digital technology. So, for example, when we work with, homeless substance users, they have mobile devices. We work in low and middle income countries that might not have clean water or landline infrastructure, but they have mobile devices. And so it's just an opportunity to harness the availability of these tools and think creatively about how can we use this in the health space. So again, as I mentioned, digital health is referring to the use of these tools for resource delivery. And there has been now probably a couple of decades of research looking at how digital tools can be useful in delivery of care. And our work has been heavily in the space of behavioral health, and behavioral health largely refers to areas like substance use disorders and mental health disorders, but it's even broader than that because we know in sort of the science of behavior change and how we can think about health behavior broadly that there are lots of transdiagnostic approaches that work across lots of health domains. So our work in this space and the functionality and sort of the tools we develop and study apply to all kinds of disease populations and chronic disease management as well as preventative health. So this slide summarizes about 2 decades of research, and I just wanted to give you a snapshot of generally what the literature shows. And what it shows is that if you develop these digital interventions well, in development we could talk about this whole hour, but these tools are developed well and actually have value to the end user and relevance to their clinical experience, you can see high acceptability and engagement across a lot of diverse populations. You can see a big, robust, and replicable impact on all kinds of health behaviors and health outcomes and disease course. We have seen that interventions delivered exclusively via digital technology platforms like a mobile device can produce clinical outcomes that are comparable to what you get with clinician-delivered care. And some people really bristle at that and say, are we trying to replace clinicians with technology? But I think what's very important is to know that these tools can have active ingredients that can really exert effects and that can extend the reach of our clinician workforce. And for example, in the behavioral health space, only 1 in 10 people struggling with a behavioral health disorder either go to or can access care for that. So there's an enormous opportunity to use these evidence-based digital tools to extend the reach and the capacity for care. We've seen evidence that they can increase the quality. You can deliver sort of the state of the science care with fidelity in a way that has broad reach. We work with health economists in our center who have shown this can be cost-effective in many contexts. And these tools can be very adaptive, and we'll talk about this today, but very responsive to individuals' needs and changes over time. So as their clinical trajectories change, what might be most helpful to them in terms of therapeutic support delivered on a mobile device may change. And so we can have tools that learn and adapt and be flexible and not be sort of static tools that always work the same way. So our center, here's the website for this center if you'd like to check it out. It's called the Center for Technology and Behavioral Health. And our goal is really to bring science to this space, right? So you see all kinds of mobile apps popping up for all kinds of issues you can think of, insomnia and depression and weight management and hypertension. You see a whole landscape of this evolving. And so our sort of area in this broad spectrum is really focused on bringing scientific methods to the development, to the systematic evaluation, and to the implementation and understanding models of sustainability of sort of the most potent, the most sort of evidence-based, the most personalized tools in this space. So we have an interdisciplinary group that works together in this center. Our center grant is from the National Institute on Drug Abuse, and we have a critical mass of faculty and team members working on the topic of addiction and substance use disorders. But again, as I mentioned earlier, there's a really broad spectrum of research beyond that topic. And so at Dartmouth, we sit in the medical school. We're at the Geisel School of Medicine here, but we've been very fortunate to work with interdisciplinary teams and folks who lead different cores of our center that are from different schools and departments, including arts and sciences, including computer science, including some of the faculty here at Thayer, including the Dartmouth Institute for Health Policy. And here is sort of the broad expertise of the center. It's yes, we have experts in mental health and addiction and behavior change and chronic disease management, but we also have experts in ubiquitous computing and emerging technologies and data analytics, in implementation science and policy work, in ethics in this space, and privacy and security, because when you think about the space that we're talking about, this broad array of expertise is really important along a whole sort of translational spectrum from development to implementation to really transforming practice. So it's a very broad spectrum of science that we support with many populations. I highlight this just to show that there's generalizability of these types of approaches across a lot of populations. So yeah, we work with kids and adolescents and college students. We work with all kinds of populations diagnosed with different health conditions, a big portfolio around substance use disorders and mental health, but also chronic pain and HIV and obesity and diabetes and binge eating disorder and hypertension, among others. And the work is in many contexts, so we've had the opportunity to learn about how can these kinds of approaches have value in different settings. So not just in healthcare systems like primary care, hospitals, or emergency departments, but also addiction or mental health specialty programs, in schools, and criminal justice systems. We work with corrections partners in different parts of the country, and also direct-to-consumer types of approaches. So I'll give you some examples of these projects, but I just want to sort of put this in perspective. And it's really a center that focuses on sort of a translational spectrum of research, so different stages of science. So this is a framework that has guided or sort of reflects a sort of a big picture of the different types of research that our group is engaged in. So if you look at the stage 0, this is considered sort of basic science studies. So maybe, and even stage 1 is sort of like early intervention, sort of development and refinement. And so let's say we're developing a mobile intervention for depression. This might be where we develop a prototype and assess, is it feasible, acceptable, comprehensible, those kinds of questions. Or let's say we have a project now where we're developing a smartwatch that's intended to, through inferences from raw sensing data, measure cocaine-taking behavior. I'll tell you more about that later. But that we're trying to see, are our algorithms able to detect with precision that kind of behavior? And, are our sensing technologies sufficient with smartwatch, with wearables to do that? So that's sort of the early stage kind of development. Those are just a couple of examples of that. And then we have all kinds of experimental studies where we'll do randomized clinical trials where we'll test different interventions either in a controlled research paradigm or in sort of national, big sort of healthcare systems, and look at questions of effectiveness and cost effectiveness. And then sort of this stage is often called implementation science. And this is where we say, okay, well, we have some empirically supported digital innovation. How do we actually embed it into a real world healthcare system? And how do we understand the impact on all the relevant stakeholders, not just patients, but clinicians and payers and administrators, and how does it fit into the regulatory structure in which the system operates? So I'll tell you later about an example of an implementation science project where we're literally working with the entire country of Colombia to transform how they screen and treat behavioral health in primary care, and then the intent is from that learning to expand these models with partners in Chile and Peru. So that's a totally different type of science, and the way you do the experimental design, the way you do the outcome measurement, compared to like a lab study where we're doing some early stage sensor development, for example. But the goal along the way is to think about how do we create the most potent digital tools and the most implementable. So it's a recursive model. It's iterative. It's not really intended to be a linear sort of path, but the ideas that have all these perspectives and stages of science inform each of the stages. Okay, so what I'm going to do now is give you some examples of our work in digital therapeutics and then move on to some of the other areas that we're engaged in. So again, digital therapeutics are software tools that can directly be useful in the treatment of some disease, okay? And I'm going to give you just 3 examples. We could talk about a lot more, but I just want to highlight a few examples so you can start to see the way in which these tools might be useful and the patterns of outcomes that we see with these types of interventions. So first I'm going to talk about substance use disorders and our work in that space. Then I'll give you another example for chronic pain, and then I'll tell you about how you can actually change entire healthcare delivery models by centrally embedding digital tools, and that'll be the example of the Latin American project. Okay, so I'm not going to go into a lot of detail about this therapeutic approach, but there are very strongly evidence-based treatments for substance use disorders that include behavioral therapies that really help people understand in new ways their pattern of drug use and learn new skills and engage in new behaviors to disrupt those self-defeating patterns of drug use. There's decades of literature on this. So we developed probably the first version a couple of decades ago, a digital intervention that can benefit from, at the time it wasn't mobile technology, but it's morphed into that, but that could, at the early stages, benefit from sort of web-based tools that can help people learn and apply these skills to their daily lives. And now, literally, when you have something in your pocket, can help you implement these in the moment every day. And one of the earliest interventions we built was a digital therapeutic for substance use disorders that really focused on this therapeutic model. And this is just, it's a very intensive behavioral treatment that has like 60-some different components to it. So it's not just to enhance motivation to change behavior, it's really a behavior change sort of tool and lifestyle restructuring tool. And so I'd be happy to talk more about what this is if you'd like, but what I really want to do is just highlight this as an example of a way that you can take a science-based therapeutic intervention and offer it to patients struggling with substance use disorders and see what the impact is. So the first study I'm going to show you is a sample that we recruited for a randomized clinical trial of people struggling with opioid use disorder. So you probably have seen the media. We have been for many years now in this nation experiencing a pretty significant opioid crisis, and this community of the northeastern part of the U.S. has been particularly hard hit by this. If you haven't heard this statistic, opioids overdose is the leading cause of death of Americans under age 50. I mean, it's exceeded deaths from car crashes and HIV and gun violence. It's a really striking problem in our nation. This is the sample we recruited for this study. And what in this study, we recruited them, everybody was offered a medication. There are very effective medications for the treatment of opioid use disorder that are very important in stabilizing the brain neurochemistry of people struggling with an opioid use disorder. So everybody in this trial got that, but what we randomized on is whether or not someone also on top of that in this treatment system received access to a mobile version of this digital therapeutic that I just showed you. And what we found is that if you received a digital intervention as part of the treatment, we retained many more of those patients in addiction treatment than if they received standard treatment that included medication and sort of the counseling offered at that site, but did not offer this personalized, always accessible therapeutic support tool. We know retention in addiction treatment is a very important predictor of long-term success. The same pattern translated to opioid-taking behavior. So the way often in clinical trials you measure this is you look at urine toxicology and you look at is there evidence of drug use. So when we looked at opioid use behavior during this trial, we found that if you got this mobile tool as part of your care model, we had significantly greater abstinence from opioids than if you didn't get the tool as part of your care model. So the idea is you add this simple resource onto an existing healthcare delivery model, and you can improve clinical outcomes for the patients. We've seen this replicated a lot now. I just am giving you some examples of what we've seen. We also did a trial where we compared the mobile intervention to an exclusively clinician-delivered version of this sort of evidence-based treatment model. So it's a 3-arm randomized controlled trial here with patients with opioid use disorder. And they either went into, again, what's reflected here in the blue bar is everybody in that arm had a therapist. They saw them 3 times a week, one-on-one individual therapy sessions with this sort of gold standard model of treatment for addiction. In this red condition, basically, the bulk of the therapeutic model was entirely offloaded to the technology platform. They only checked in with their therapist periodically, but instead, the time they would have spent with the therapist, they instead spent with the digital therapeutic intervention. And then the group that's reflected in gray is considered standard treatment. It's the kind of treatment that a lot of people in the nation in outpatient addiction treatment receive, which often is not reflective of sort of best practices. So the point here in this trial, and just the graph I'm illustrating from this trial, is that even when you offload the bulk of your intervention to a technology platform, you can get outcomes that are comparable to exclusively clinician-delivered treatment. So this has a lot of implications because we don't have enough workforce to meet the population-level need around this, particularly now in light of the opioid crisis. And in rural communities, like in some of our communities, we have no capacity for this. So the idea is how can this type of tool be used to expand the capacity and reach of evidence-based care? One more example, and I'll just, in sake of time, just give you one more example. This is another trial. We ran this in New York City, and it was a group entering outpatient treatment for opioid taking again. And in this case, when people came in, everybody got medication, and people in standard treatment, the treatment as usual group, saw a counselor, 60-minute sessions individually a few times a week. And the other group, we literally cut in half the patient-clinician contact time. And let's say instead of a 60-minute session, we'd say meet with the therapist for 30 minutes and spend the other 30 minutes in a lab on site at this facility interacting in a personal way, one-on-one way with the digital intervention. And when we cut in half patient-clinician contact time and replace that time with access to this digital therapeutic, we saw a marked increase in clinical outcomes. We saw a marked increase in people's ability to give opioid-negative urine samples. We saw people stuck in treatment longer because we were delivering in an interactive way with fidelity sort of the state-of-the-art treatment that may not have been what they were receiving by the clinician. There's a ton of variability in what happens with clinicians. So we see that you can increase the potency of the therapeutic intervention and increase clinical outcomes with these types of tools. Then there was a big national trial that looked at this that basically found the same pattern. So if you're not aware of what's involved in the FDA space around this, it may be of interest to you. So the Food and Drug Administration has created a new category of medical device, under medical devices, that they now review for safety and efficacy data to give market authorization to what are called prescription digital therapeutics. So this is going to explode. The FDA is now inundated with applications around this, but this is something you should be aware of because the future of digital I think the future of healthcare is essentially going to embrace digital medicine. And so what this means is that if you present rigorous clinical trials data to the FDA, not unlike a pharma company, let's say, would do with a compound they want for consideration for FDA approval as a medication, they will review it for safety and efficacy to say that they will or will not give market authorization that this software can be prescribed to treat disease. So now we have a world where clinicians can prescribe software to treat disease. So the work we did for a few decades, I think, on the digital therapeutic for substance use disorder was able to become the first FDA-approved prescription digital therapeutic in the U.S. It was in September of 2017, and now there are several other FDA-approved in this space. So literally a prescriber, let's say you're a primary care physician and you identify someone struggling with depression, or you identify someone struggling with an opioid use disorder, you can manage that with services you can offer in primary care, maybe medications that you could offer as a provider. You can also write a script to that patient to engage in, let's say, 12 weeks of a behavioral treatment that's entirely delivered through a prescription digital therapeutic. So this is something you should be aware of because this is really, the regulatory space around this has been very interesting how it's been evolving, and I think it's going to rapidly evolve. Okay. I think in the interest of time, I'm going to skip this. Basically, I was going to give you another example showing a similar sort of pattern of outcomes when we offer digital therapeutics for people struggling with chronic pain, to the point we can even reduce emergency department visits if you give people these tools as part of treatment. But for the sake of time, I'm going to jump into our project in Latin America because this is an example of, okay, well, clinical trials work is interesting and rigorous, but how do you take that and really scale it up to actually impact care? So that's what we're trying to do in this project in Latin America. This is funded by the National Institute of Mental Health. And our current country we're working in is Colombia, and for those of you that know much about Colombia, it's a country that has been heavily impacted by violence and conflict, and there are very high rates of trauma and very high rates of depression and high rates of binge drinking, very high rates of alcohol use disorders, including alcohol use disorders that are associated with domestic violence. But if you look at what's the clinician workforce, what's the healthcare access to help people struggling with this across the nation, it's very limited. And maybe you might have mental health professionals in Bogota or more urban contexts, but if you go to rural farming communities in Colombia where the need is still high, the resources are very limited. So this project is focused on how can we, in a country with high need but little capacity, try to scale up access to evidence-based behavioral health treatment. So we heavily do this by offloading a lot of the therapeutic model to digital platform. So we're working in primary care. So we are for the first time training primary care providers to learn about what is depression, for example, and really sort of embrace that. But the whole this is a partnership with our group and a wonderful group at Javeriana University in Columbia and a lot of very diverse stakeholders, Ministry of Health, industry payers, a lot of other folks. So the digital piece has multiple components, including the entire process of screening and diagnosing is automated using validated sort of assessment tools. The providers are sort of we have a system that sort of holds their hand in the entire process of diagnosing and providing treatment to people according to best practices through clinical decision support tools. And then every patient who is identified with these problems gets personalized digital therapeutic platform, which is a platform that can provide them, in their home. They take it with them, accessible anywhere, treatment resources entirely delivered in an interactive software way that doesn't depend on synchronous communication with the clinician. So we've been trying to study, can we, with this heavy support from digital technology, transform healthcare models to embrace science-based care around this, and is this a way to increase capacity? So people come in, they get screened. Could be some of the sites like to do it on a kiosk, some on tablets, and then the whole thing is automated thereafter. So I don't need to go into a lot of details of this, but I think it's exciting because it's an opportunity to look at sort of systems-level outcomes. This is just an example of what the clinician does. This is our patient digital therapeutic in Spanish. We've modified the whole thing to be culturally appropriate for Latin America, but this is the intensive treatment here. So we're doing this with a couple thousand people, and really we're looking at it, how does this impact the organization's functioning capacity for care? How does it impact workflow? How does it impact cost? Not just cost effectiveness, but like the cost of all the processes that happen in this context. There's a lot of data also on patient outcomes with this. So it's an example of a project where we can learn a lot about implementation and sustainability. Okay, so I tried to give you some examples about digital therapeutics and how they can impact different health conditions. Those are just examples. We have seen the kinds of patterns I showed you with the addiction work. We have seen those kinds of patterns in all kinds of populations when we work with people trying to quit smoking, people with severe mental illnesses, people who've got trauma histories, people who are engaging in risk behavior, people who aren't adherent to medical regimens like taking medications or other medical regimens for chronic disease management. We have found that if you really embed sort of the science of behavior change and sort of best practices in these tools, but also embrace what the tools can really do uniquely with the kind of functionality you can build into something that's literally with you all the time, that you can get these very marked increases in patient clinical outcomes for all kinds of populations. And so one of the things we've been very excited about, and I'll just mention it briefly, is the opportunity to transcend some of our siloed models of disease treatment, right? Because, we specialize in certain things and we have people who treat this but not that. We have therapeutic, even in the behavioral health space, we have people that treat addiction but not mental health, even though these things often go together in very clinically meaningful ways. So as we've had the opportunity to do this work, we've seen there are really active ingredients and very specific ways we can embrace the functionality of mobile devices to give people therapeutic resources that have the biggest impact, that transcend disease. So we've created a system that really is designed to not just be an app for insomnia or for alcohol or for depression or for binge eating or for panic disorder, but really to have a system that can flexibly deliver digital therapeutics and combined approaches to care for whatever combination of needs and preferences people present with. So if it's depression and alcohol, there's a unique offering for that person. If it's hypertension and insomnia, it's a different combination of tools. So the idea is that maybe this could be a flexible model that can be more broadly relevant and not have sort of a whole series of siloed approaches. So I think I've tried to underscore that we have been very excited about the data that we've seen now in this literature and the work that we've been able to engage in, and the opportunities to scale up the science of this and have an impact on how we think of care models. But one of the many areas we're excited about now to expand this is to think about, we can get such rich information about people through digital technologies, right? From things that they wear, from from responses to queries that we might ask them to respond to, and to apply analytics to these types of digitally derived data that can help us learn a lot about people at a very individual level, at a very granular level, to really understand sort of momentary data as they move through their daily lives. And not only can it help us, I think, understand human behavior and health behavior better and in new ways and advance our theoretical models of like how do we think about health behavior, but this is one of the things we're heavily focused on is how can we take these sort of digital metrics and these digital assessment data to inform digital therapeutic work and really have personalized, responsive, in the moment therapeutic approaches that we offer at an individual level by the intersection of these areas. And so let me just skip to this page. So our center work, and these are not mutually exclusive categories. I just sort of put these in buckets for discussion purposes. But yes, we work in this digital therapeutic space, but we're doing a lot of work around mobile sensing and sensing on smartphones to infer information about people's health and behavior and physiology that also can inform intervention delivery. Some of our faculty are heavily involved in looking at social media data. People produce in large volumes as consumer-generated, unstructured information that you can get all kinds of information about people from, including, you know, if someone's depressed, if someone might be at risk of suicide, if someone might have problems with substances. There's even much richer information you can get from analytics you can apply to social media data, looking at images, looking at topology of social networks, looking at communications. And there's a lot of innovation in the space of data analytics in this space because we have this huge volume of rich, intensive, longitudinal data that we have to derive some meaning from. And how do you best do that? And can you do that at the individual level? Can you have some, you know, so for an example, some of our faculty are working on like idiographic machine learning methodologies that can really look at the personalized data of an individual. So let me tell you about one example, and then I'll tell you a bit more broadly about some other things going on. So we're doing a study now funded by NIH on digital phenotyping. So have you guys heard this term? Anybody heard this term, digital phenotyping? So it's basically sort of this moment-by-moment measurement of individual level data. And often it's through passive sensing, like through a smartwatch, or also using a lot of the sensors on a smartphone. But in our study, it's very exploratory, but we're looking at multiple data sources. So we're looking at data collected on mobile devices through passive sensing. We're asking people if they would let us pull all of their social media data, anything they've got, Twitter, Instagram, Facebook, anything, images, text, everything, posts. And we're also asking people to respond to a set of structured questions that we prompt them to respond to on mobile devices, very short little spurts where we will ask them to respond about sort of in this moment we want their responses. So we're doing this with a patient population of people in treatment for opioid use disorder. That's an example I cited earlier. But we know even when people get in treatment, and there are effective treatments, but even when people get in treatment, we have a lot of relapses to opiate use. We have a lot of non-adherence to medication taking, which often sets people up for relapse. We have a lot of people drop out or just not show up at appointments. And we have some high-level information about factors that contribute to that. But this study is focused on what can we really understand about what confluence of factors might really predict these events, these really clinically meaningful events that could affect this clinical course for this individual, and also at the individual level, so that we might better understand how do we best keep people in treatment? How can we provide sort of responsive support, therapeutic support to people that can help prevent these sort of negative clinical outcomes, like people sort of relapsing, which then often leads to further relapse. So we're through smartwatch sensing and also phone sensing. These are a lot of the sensors that we're getting, and we can infer a lot of information about like sleep and activity levels and even some paralinguistic aspects of people's speech, which has been predictive of certain things, including mental health states. We are prompting people, the term that's used sometimes is ecological momentary assessments, or EMA. It's just sort of these queries where you prompt people to respond about their sleep and their current stress and their current pain and their withdrawal symptoms and the mood and the context and maybe exposure to risk scenarios, and really trying to understand sort of factors that could influence some of these events. The last term, MOUD, is medication treatment for opioid use disorder, so adherence to effective, really life-saving medications. And then again, from social media data, pulling all these data and very much exploratory analysis of this. So this is a partnership with people at our center, including in CS and in also biomedical data science. We have engaged IBM Computational Health as a partner on this, which has been great. And then all of our data are collected from patients in the Kaiser Permanente system, where we can link all of this digital data to claims data and electronic health record data as well, to understand how these digital data could enhance our understanding of the clinical course of these patients. So why are we doing this? Well, one is that in clinical trials, if you think about, okay, I want to test intervention X for this treatment of some disease, a lot of times the way we do that is very standardized, validated clinical assessments, which are very helpful, like sort of in the addiction world, like looking at urine toxicology data at very specified intervals over time, looking at are people engaged in treatment, looking at all kinds of factors about sort of their stability clinically. But the question is, can we punctuate those episodic sort of data that you collect in these clinical, these validated assessment tools with digital data that might give us a richer picture about people's daily lives, right? Not just these standardized measures, but really understanding in a more granular way things that happen that really influence clinical outcomes in intervention trials, let's say, or in disease course, and really trying to understand and develop contextual models of people's health behavior. And then ultimately the goal is, and there's some people, including in our shop but elsewhere, trying to take these types of data and insights to inform real-time, in-the-moment intervention delivery. You know, what is the right amount of therapeutic support at the right time that's responsive to that profile, that risk profile for that individual. So it's really trying to link this measurement world to the intervention world. So that's just an example of a project we're really excited about, and it hasn't been done yet with this population of opioid use disorder. And there's a lot of evidence in the current opioid epidemic in the U.S. that there are lots of different sort of trajectories of people struggling with opioid use disorder, so this might help us better understand what's going on there. Okay, I'm going to give you a little snapshot of some things that we're up to, just to give you a little flavor of some other projects, but glad to talk about any of these in more detail. I mentioned this smartwatch to detect cocaine use. We know this has no market value. Nobody's going to buy a smartwatch to measure their cocaine-taking behavior. But so this is funded by the National Institute on Drug Abuse, and the reason that they're very interested in this is we don't have a lot of effective treatments for cocaine addiction. And there's all this work trying to test novel therapeutics for cocaine addiction. But if you want to say, does this thing work or not? Well, if you look at urine data and it says they're cocaine positive, we know maybe in the last 3 days someone used cocaine. It's not very detailed. So the idea here is that if we can really detect dose of cocaine taking, duration, sort of all kinds of temporal information about cocaine use events, we can get much more detailed data about an outcome measure of great interest in these clinical trials. So the idea here is to develop a device that can be used to enhance outcome measurement in clinical trials. Some of our colleagues, including some folks at Thayer, are part of these projects on computational jewelry, bracelets, earrings. I think some people call it geek chic, for mobile health sensing. Smart earpiece, some of you might be involved in the Oracle project, a wearable sensor to measure eating behavior. It's very early stage, but there's thought that this could have implications in eating disorder populations. We have a lot of folks working on cannabis-related issues and some treatments for cannabis use disorder that include some sensing data. We just hired a new faculty member who's doing a lot of work in digital phenotyping and depression and anxiety. looking at something called self-regulation, which is a concept that affects a lot of populations, and we're looking at momentary self-regulation and sort of diagnostic measures of self-regulation across like heavy smokers or people with binge eating disorder with a lot of granular sensing and EMA data, ecological momentary assessment. Sensing context. So we have some colleagues here that are very interested in not just getting sensing data from the individual, but measuring context around them through sensing data to help have context-informed data around this. Intervention delivery, like I said, adaptive interventions. Digital epidemiology, I wonder if you guys have heard this term. So this is where you sort of do, so epidemiology you can think of sort of like national survey work and sort of measurement of trends. Well, this is doing all of that online with very targeted recruitment and trying to have methods that can produce replicable sort of outcomes. And some people are doing this in our shop, including we have a rapidly changing world of access to cannabis and legislation around cannabis. And there are all kinds of nuances of cannabis laws across the U.S. And so we have someone who's been leading a lot of digital epidemiology research, trying to understand in systematic ways that rapidly evolving national landscape entirely through a digital epidemiology approach. I told you a bit about the social media data with some of the deep learning models to glean insights from about behavioral health through that kind of data. And then I'll just briefly mention this last one, which is a project focused on online recruitment and entirely remote delivery. So if you want to recruit a really hard to reach, sample that may be hidden and really tough to access for research, there are we've seen opportunities to do that online, where you can have very targeted advertisement and very remote care models that you can test, including in clinical trials, entirely online. So this is a study where we're engaging very high-risk populations for HIV in states like Mississippi and Alabama and other states where we have seen higher rates of HIV, where we can recruit these individuals for participation in trials of remote-free HIV testing and then linkage to PrEP, which is a preventative prophylaxis treatment that's been shown to be very protective against HIV. And the whole thing is done using social media. So that's just an example of another way you can think about these types of data. So overall, I'm very excited about opportunities to learn more about human behavior and advance our understanding of behavior with these tools. To understand, we really need a lot more work in mechanisms of action. We've studied a lot, like when we change drug use with a mobile intervention, how did we do that? And we've learned a lot about that, but really understanding the active ingredients and the core mechanisms by which these tools work is an understudied area that I think there's a lot of opportunity to expand. Again, this opportunity to have these responsive, adaptive, personalized tools in this space, to have these sort of just-in-time interventions, that's the term people use sometimes, to have these momentary interventions. One of the areas we're going to move more heavily into, and if folks are interested, I'd love to engage with you about this. We don't have enough active dialogue, I think, about the ethics in the space of digital health and digital health research, and there's a lot of opportunity here, and a lot of people are very worried about privacy, understandably, but there's also very clear evidence that a lot of patients want data to flow and to flow in certain ways because it has value to them. And so really understanding that and providing frameworks to inform that and addressing fears that some communities have around that in a balanced way, I think is a tremendous opportunity. As is our center has been asked to sort of expand our work in trying to support a regulatory pipeline for the FDA sort of process around these prescription digital therapeutics, which is a great model because, patients will know which ones have gotten sort of FDA vetted. But I still very strongly believe that we should not wed access to these tools just to healthcare systems, but that we should have lots of flexible points of access, including a lot of ways we can think about direct-to-consumer business models. So I'll stop there. I think, the point of this really was to show that this is, we think, the data support an opportunity for sort of generalizable approaches that can be applied to lots of areas of health and wellness and can provide widespread reach and scalability really globally. I mean, I think the opportunity is there. And, we hear this term precision medicine, but I think this is another way we can think about, or personalized medicine, how we can think about ways to take these types of data, digitally obtained data to inform new ways to think about and enhance some of the ways we're doing personalized medicine. So I will stop there. There's my contact info and our website again. And again, thank you for the opportunity to talk with you about this today and take some questions. Thanks.